So objective 3 is to explain the control of water balance and osmolarity by antidiuretic hormone. And we kind of began speaking about antidiuretic hormone, or ADH, and we talked about how it regulates the distal part of the tubule. So we kind of connected this to when we kept mentioning that the distal tubule and the collecting duct are involved in regulated water reabsorption, and that regulation is the influence of the hormone ADH. So ADH basically regulates the permeability of the distal tubule by inserting those aquaporin 2 channels. And so this is what allows the range that I mentioned, the range of the osmolarity of urine. It can be as watery and as dilute as 100 milliosmoles, or it can be as concentrated as 1400 milliosmoles. And this range, this regulation is under the influence of ADH, which inserts more aquaporin 2 channels into the membrane. So let's look at how ADH does this. So remember, ADH is coming from the posterior pituitary. We'll talk about some of the stimuli for ADH release in a minute, but once it's floating around in the blood, it's circulating in the plasma, it's going to make its way to the kidneys where it has its effect. It's going to bind to the basolateral surface of the principal cells of the kidneys. And so remember, I talked about the distal tubule and collecting duct having some uniquely named cells. The principal cells was one of them. And so ADH binds to a receptor here on this cell. It's going to have some sort of second messenger cascade. We talked about this metabotropic response, where it binds to a G protein receptor. That has a configurational change. One of the subunits activate an amplifier enzyme downstream in the membrane. In this case, it's adenylate cyclase. And then that creates second messenger. In this case, it's cyclic AMP. And that influences the production of these aquaporin 2 channels. And then they can be transported and inserted into the membrane. Now, when they're inserted into the membrane, right, remember what an aquaporin 2 channel is. It's simply a water channel. So if we have more of these channels in the membrane, we can reabsorb more water across the apical surface. And then if you remember, I also talked about aquaporin 3 channels. These are also aquaporin channels, but they are always present in the basolateral surface. So the regulation is really controlling the aquaporin 2s, which are in the apical surface, and then water can simply be reabsorbed into the cell and across the basolateral surface by the aquaporin 3s. And so this is how ADH influences water reabsorption in those distal parts of the tubule, okay? So I'm gonna skip over those remaining slides. So the regulation of ADH secretion takes place in the posterior pituitary where it's secreted. It's coming from cells that are in the hypothalamus. It's the osmoreceptor cells in the organum vasculosum of laminae terminalis. Very long, fancy word, OVLT for short, but these are basically osmoreceptors that are detecting the osmolarity of plasma. They're sensitive to the osmolarity of plasma. And they are going to determine whether or not the osmolarity needs to be regulated. And in doing so, they're going to determine whether or not ADH needs to be secreted or not. Now, the OVLT is not surrounded by the blood-brain barrier. And if you remember the blood-brain barrier, it's kind of a barrier standing in between what's happening in the plasma, in the blood, and what's happening in the nervous tissue. And that is typically a protective measure in the brain. But because the OVLT needs to have an accurate sense of what's happening in the plasma, there is no blood-brain barrier standing in between the OVLT and the plasma. So it's going to get a better representation of what the plasma osmolarity looks like. ADH is also affected by baroreceptors, right? So blood volume and blood pressure are going to be other stimuli for ADH. So if we have decreased baroreceptor activity, meaning decreased blood volume, decreased stretch, of these baroreceptors, then that is also going to be a stimulus for ADH secretion. So the OVLT, which is determining the plasma osmolarity, and the baroreceptors, which are determining the blood pressure and blood volume, are the stimuli for ADH. So let's go through this flow chart, which kind of gives an example of how that happens, of how the ADH is secreted and how it regulates water reabsorption. So let's say we have an instance of increased osmolarity of our extracellular fluid, of our plasma. And again, in terms of a practical example, increased osmolarity means that your plasma is too concentrated. So think about hemorrhage, think about, again, dehydration, where you're losing excess volume. And so what's left back in your plasma is concentrated, right? It doesn't have adequate amounts of water in it. And so that is going to be the initial stimulus. The hypothalamus, the osmoreceptors in the OVLT will detect this increase in osmolarity, and they're going to respond by activating the hypothalamus to secrete ADH from the posterior pituitary. Now, just to kind of clarify this bit here, remember the hypothalamus is where the neurons that are releasing this ADH are stored. This is where the ADH is being made, but the terminal ends of these neurons are down in the posterior pituitary. Remember the anatomy of the posterior pituitary and the hypothalamus. So it's going to activate the hypothalamus, but the response is going to happen down in the posterior pituitary where those terminal nerve endings are. So ADH is going to be secreted or released from the posterior pituitary. It's going to circulate in the blood, make its way to the kidneys. It's going to, that entire second messenger cascade that I just went over, resulting in insertion of the aquaporin tools into the apical surface of these principal cells, and that's going to facilitate more water being reabsorbed into the plasma from the tubular fluid. And so that's going to be the body's response to conserve more water in times of dehydration, in times of hemorrhage or shock. And then obviously when we have restored the plasma osmolarity by reabsorbing more water, we're going to correct that initial imbalance, and that's going to be a negative feedback onto the osmolarity and onto the OVLT. Okay, here is another flow chart that kind of looks at a different scenario. Well, this is the exact same scenario, but this is showing the second response. So this is not the OVLT, but this is the baroreceptor response instead. So same scenario happening here, hemorrhage, dehydration, resulting in decrease in mean arterial pressure, resulting in decreased blood volume, and then that's going to stimulate the baroreceptors. They're having less stretch because blood volume and blood pressure is decreased. They're going to stimulate the hypothalamus to communicate to the posterior pituitary to secrete ADH. That's going to have the same effect. That's going to have increasing water reabsorption, correction of that initial error, and turning that off via a negative feedback loop. Okay, so the same stimulus, the same end result, but two different mechanisms. One is via the OVLT and those osmoreceptors, and one is via the baroreceptors and their detecting of stretch in the vessels. Okay. Lastly here, let's speak about the regulation of water reabsorption by changing GFR. So we talked about the auto-regulation of GFR. And just to kind of jog your memory, we looked at that graph where we saw GFR stays at 125 for a mean arterial pressure between 80 and 180. And we talked about the three mechanisms that kept GFR regulated, right? The myogenic regulation, the tubuloglomerular feedback, and the mesangial cells. So those are the three mechanisms that help to auto-regulate GFR as long as mean arterial pressure is in between 80 and 180. Now, if mean arterial pressure drops below 80, the kidneys are no longer going to auto-regulate here. They're going to take the loss, take the hit, and they're going to decrease GFR. They're going to decrease the amount of water filtered and decrease the amount of water excreted in order to hold on to more water to try to correct that imbalance, okay? And the mechanism by which this happens is sympathetic innervation. Remember, sympathetic influence to the kidneys results in decrease in the diameter of the afferent and efferent arterioles, which is increasing the resistance in those arterioles, and that's going to result in less blood coming into the glomerulus, which will decrease GFR, which will decrease the amount of water that's coming through it. The opposite scenario is if blood pressure rises greater than 180. And again, the kidneys are not going to auto-regulate if blood pressure goes above 180. They are going to increase the flow into the kidneys, increase the GFR, increase the amount of water filtered, and then increase the amount of water excreted. And again, two kind of practical scenarios here are going to be a drop less than 80 being hemorrhage, dehydration, shock. And the end result of decreasing water excretion is going to be to correct that, right? If we're hemorrhaging, we want to try to hold on to conserve more water. And then a scenario for this other end of the spectrum would be chronic hypertension. So if you think about someone who has chronic sustained high blood pressure, this is the message that's being sent to the kidneys. Increase in blood pressure greater than 180. That's going to result in increased GFR. More water is going to be filtered through the kidney so that we can lose or excrete more water in an effort to decrease the blood pressure. And this is why typically hypertensive patients are prescribed diuretics so that they can kind of lose some of that water. That excess water is what is contributing to the excess blood pressure. And so the kidney's natural response is to excrete more water in an attempt to correct or drop the blood pressure. And that's the basis behind giving diuretics to hypertensive patients as well. Okay. All right, let me see if there are any questions. Okay, so let's look at these two checkpoint questions briefly. Name two stimuli for ADH release from the posterior pituitary. So the two stimuli that we talked about were the osmoreceptors in the OVLT. When they detect an increase in plasma osmolarity, they're going to secrete ADH. The second stimulus was a decrease in the baroreceptor stretch, and that is going to be a second stimuli for ADH. And both of those are going to bring about the same response, right? Reabsorbing more water, conserving more water in effort to correct the blood volume and blood pressure. The second question, describe the effects of ADH on principal cells. So again, similar kind of theme here. So ADH is going to bind to that receptor on the basolateral surface, bring about the whole second messenger cascade, and insert more aquaporin 2 channels in the apical surface. And that's going to facilitate more water being reabsorbed in the principal cells and into the plasma. Okay, so that's the end of our second packet. Let's move swiftly along. We're going to move on to renal balance part 3. Oops. What was that part 2? Yeah, that was part 2, sorry. So we're going to move on. That was part 1, excuse me. So we're going to move on to part 2. Okay, so here are the objectives for this second packet. Please bear in mind, we're going to eliminate calcium balance, so completely cross off objective 4. We're not going to talk about calcium balance, but we will speak about aldosterone and ANP, atrial natriuretic peptide, and how they influence sodium levels. We're going to talk about the stimuli for these hormones. And then we're going to speak about how the major mechanisms of water and sodium balance influence mean arterial pressure. Now, when I say mean arterial pressure, in your mind, you should be thinking blood pressure, right? Those two things are synonymous. So the overall perfusion pressure, blood pressure, mean arterial pressure, those are indicating the same thing. And then the third objective here, explain the role of aldosterone in potassium balance. So aldosterone kind of has this twofold effect. It influences sodium, but it also influences potassium as well. So we'll talk about how that is related. So in regards to sodium balance, we can kind of speak about hypernatremia and hyponatremia, very similar to what we talked about with water balance. So hypernatremia is a state of high plasma sodium. This is synonymous with high osmolarity, meaning that we have a very concentrated, very salty plasma osmolarity, whereas hyponatremia is a state of low plasma sodium, again, synonymous with low plasma osmolarity, a very diluted, a very watery plasma. And so sodium is going to be the primary solute in our ECF, in our plasma. It's going to be critical for normal osmotic pressure, so maintaining our blood pressure. It's also going to be important for excitable cells. Think about your neurons, think about your muscle cells. When they stimulate an action potential, what's happening, right? Sodium is rushing into the cell. So we can't have an action potential if we don't have adequate sodium. So on a very basic level, sodium is very important to be in just the right quantity in our extracellular fluid. So sodium is freely filtered across the glomerulus. It is reabsorbed in the proximal tubules, most of it, 70 to 80% of it. And then some of it happens in the distal tubule and collecting duct as well. It is not secreted, so it's never secreted into the urine. The reabsorption is regulated in the distal tubule and collecting duct under the influence of the hormones aldosterone and ANP. We'll talk about what ANP stands for later on, but these are the two hormones that regulate sodium's reabsorption. The reabsorption happens in the principal cells of the collecting duct and distal tubule. So those same cells where we mentioned the aquaporin 2s are the same cells that are being influenced in order for sodium to be reabsorbed. The reabsorption is active, meaning it's going to require energy, and we know that because it's using the sodium-potassium pump, which is an active form of transport, which is on the basolateral surface. Okay, so let's actually describe what this reabsorption mechanism looks like. So just to remind ourselves here, the anatomy, we've got the lumen, where we have tubular fluid, we've got the epithelial cells of the proximal tubule, we've got the peritubular space, and we have the endothelial cells of the capillary, right? And then the plasma. So in order for sodium to be reabsorbed, it's going to be passively moved into the cell, and we know this, right? There's decreased sodium in the cell because of the sodium-potassium pump, so we already have a sodium gradient. So higher sodium here, less sodium here creates a passive movement of sodium. And then it's going to be actively pumped across the basolateral surface using the sodium-potassium pump. So this is how sodium is reabsorbed from tubular fluid into the blood vessels. In the distal tubule, we have a similar phenomenon happening, but we also have leak channels for sodium. So this is what we mean by the distal part of the tubule being regulated. These leak channels are going to be inserted here under the influence of certain hormones that I'm going to talk about. So here it's going to be regulated, whereas here it's not going to be regulated, right? It's just going to leak into the cell, whereas here, specific leak channels just for sodium will be inserted, and that's going to increase the amount of sodium that can be reabsorbed. And then the same mechanism happens across the basolateral surface. It's actively pumped via the sodium-potassium pump. So just to point out the difference between the regulated reabsorption of sodium in the distal parts of the tubule and collecting duct and the non-regulated reabsorption in the proximal tubule. Okay, let's talk about how aldosterone plays into all of this. So aldosterone increases the reabsorption of sodium. It's a hormone that's released from the adrenal cortex. So just to kind of flash back here, the adrenal are these glands, endocrine glands that sit on top of the kidney. They have two distinct regions, the medulla and the cortex. Just to kind of jog your memory, we talked about the medulla when you look at the autonomic nervous system, and the cortex is really involved in glucocorticoid, steroid hormone secretion, and then importantly, aldosterone secretion as well. So when aldosterone is released from the adrenal cortex, it's going to make its way in the blood. It's going to enter the cell here, bind to this cytosolic receptor, and influence the insertion of these leak sodium and potassium channels into the apical surface of these cells. And what that does is it increases the reabsorption of sodium. So not only is it inserting leak channels for sodium and potassium, but it's also inserting sodium and potassium pumps in the basolateral membrane. So its action is kind of twofold here, but both of these actions are resulting in more sodium reabsorption. So more sodium is being leaked in via these leak channels that are inserted into the apical surface, and then more sodium is being pumped across the basolateral surface by these sodium-potassium pumps, okay? I want you to stick a pin in your mind, the fact that it's also inserting potassium channels. We're going to talk a little bit later on about how aldosterone influences potassium, but I want you to kind of come back to this image of aldosterone also inserting leak potassium channels into the membrane and sodium potassium pumps. So it's also going to influence potassium, but as we can see, it's going to be in the opposite direction. Okay, and we'll talk about that a few slides down. Let's now speak about the renin-angiotensin-aldosterone system. So the renin-angiotensin-aldosterone system, also called the RAS system, is a sequence of events, right? A sequence of cells secreting hormones that eventually result in aldosterone being secreted, okay? So we talked about aldosterone coming from the adrenal cortex, but now we're going to talk about what are the precursor events that facilitate aldosterone being released from the adrenal cortex. So the first thing is that we have granular cells of the juxtaglomerular apparatus. And I talked about the juxtaglomerular complex or apparatus a bit earlier on. I talked about the 3 cells that are part of that apparatus, the mesangial cells, the extramesangial cells, the granular cells, which we're going to be referring to now, and then the macula densa cells. So the granular cells of that apparatus release renin. And renin is going to be released into the blood. And when it comes into contact with angiotensinogen, now angiotensinogen is an enzyme coming from the liver. It's always circulating in the blood, but this suffix, GEN, tells us that although it's circulating in the blood at all times, it is not activated. It's in its inactivated state. But when it comes into contact with renin, it will now be activated into angiotensin 1. Okay, and I'll kind of say that again, just so that it's not confusing. The liver is always secreting angiotensinogen in its inactivated form. When it comes into contact with renin, which is being secreted from the juxtaglomerular granular cells, then it will be activated into angiotensin 1. Now, angiotensin 1 is going to be converted into angiotensin 2 by the enzyme called ACE. So ACE stands for angiotensin converting enzyme, and it's an enzyme that is found by made by our capillary endothelial cells. And when angiotensin 1 comes into contact with ACE, it's converted into angiotensin 2. Now, angiotensin 2 is what directly stimulates the adrenal cortex to make aldosterone. Okay, so this is what we mean by that renin-angiotensin-aldosterone system, right? Renin activates angiotensin 1, activates angiotensin 2 by the enzyme ACE, and then angiotensin 2 stimulates the adrenal cortex to make aldosterone. Okay. So, under the influence of angiotensin 2, let's talk about all that's going to happen. So although angiotensin 2 is directly stimulating the release of aldosterone from the adrenal cortex, it's going to have some other effects as well. It's going to stimulate vasoconstriction of our systemic arterioles. That is going to increase mean arterial pressure or increase blood pressure. It's going to, as we said, increase aldosterone release. That's going to facilitate sodium reabsorption in the distal tubules via the mechanisms that we just described. That's going to increase the extracellular fluid osmolarity as that sodium is reabsorbed. A third effect is that it's going to influence the posterior pituitary to secrete ADH, okay? And if we think about this, remember that the plasma osmolarity via the OVLT is another stimulator for this ADH secretion. So something we just talked about. So both of these are influencing the ADH secretion from the posterior pituitary. That ADH is going to, via aquaporin 2 channels, increase water reabsorption, which is going to increase plasma volume, another effort to correct that plasma volume, correct that mean arterial pressure. And then the fourth response is going to be stimulating hypothalamic neurons to increase the thirst stimulation in the brain. This is going to make you more thirsty. This is going to trigger you to drink more water, intake more fluids, again, in an effort to correct your plasma volume disturbance and correct your mean arterial pressure or restore your blood pressure. So the stimuli for angiotensin 2 are basically, anything that has dropped mean arterial pressure. Again, shock, hemorrhage, dehydration. And so the four mechanisms of correcting that all lead to an increase in mean arterial pressure, some influencing plasma volume through water, some influencing plasma osmolarity through sodium, and then the systemic arterioles simply vasoconstricting to directly influence that pressure. So let's kind of summarize here and look at the stimuli for renin. So the stimuli for renin are decreased pressure in the afferent arteriole, renal sympathetic nerve activity, or decrease in sodium and chloride presence in the distal tubule filtrate. So all of this translates to those three scenarios: dehydration, shock, or hemorrhage, right? Decrease in pressure to the afferent arteriole, decrease in the sympathetic activities, and decrease in sodium in the distal filtrate. So again, that's just kind of tying these three things together. A drop in mean arterial pressure is going to stimulate a decrease in the afferent arterial pressure, a decrease in the baroreceptor reflex, which increases the sympathetic activity, and then a decrease in GFR, which is going to decrease the amount of sodium and chloride in the distal tubules. So these are the responses that we see if someone is bleeding out or dehydrated, right? And this is why we see those responses. And then the correction is going to be an increase in renin release, which will increase angiotensin, increase aldosterone in an attempt to correct that initial mean arterial pressure disturbance. Okay, let's talk here a little bit about ANP. So ANP is, right off the back, I want you to think of it as the evil stepbrother or the opposite of aldosterone. So aldosterone and ANP, they're opposite ends of the spectrum. They're doing opposite things, okay? ANP is secreted by the atrial cells of the heart, so cells in the atrial wall, and ANP is secreted in response to increased distension or increased stretch of the atrium. And if you think about what increased stretch of the atrium means, this means that there's excess blood volume. So this is the opposite stimuli of renin. Remember, the stimuli for renin was decrease in blood volume. The stimulus for ANP is excess blood volume, excess blood pressure. And so when the cells of the atrial wall feel that extra distension, they're going to secrete ANP. ANP is directly going to increase GFR by dilating the afferent arterioles and constricting the efferent arterioles, which will eventually push more blood into the glomerulus and increase GFR. The result of this is going to be decreasing sodium reabsorption by closing the sodium channels in the apical membrane of the distal parts of the tubule and increasing the amount of sodium that is excreted or lost in the urine. Now, if you think about this practically, this is what we want if we have extra blood pressure. Again, think about your chronically hypertensive patient. They have excess stress on the heart. This is why hypertensive usually have heart failure, because of that increased volume, increased work that the heart has to do with all of that blood volume circulating. And so the basis, the end goal here is to try to lose some of that sodium and lose some of that water in an effort to decrease blood pressure back to normal. So the two things we do is we facilitate more sodium reabsorption. We decrease sodium reabsorption, by removing or closing some of those channels to help the body lose some of that sodium. So here's a flow chart again, the stimulus being increase in plasma volume, the initial responses being atrial wall stretch, which stimulates ANP being secreted from the atrial walls, and ANP is going to dilate the afferent arterioles, pushing more blood into the glomerulus, constrict the efferent arterioles, which further pushes or forces more blood to go into the glomerulus, increasing glomerular capillary pressure, increasing GFR. It's also going to decrease the amount of sodium reabsorbed in the distal parts of the tubule by closing or blocking those sodium channels on the apical membrane. And both of those things translate to increased sodium excretion or sodium being lost in the urine. And then finally, it's going to decrease renin secretion. Remember, the stimulus for renin is decreased plasma volume, so dehydration, hemorrhage. And so because this is the opposite scenario, we're going to stop or decrease renin secretion. And so we're going to decrease aldosterone. That is also going to facilitate more sodium excretion, because if you remember, aldosterone wants to reabsorb sodium. So if we decrease it, we're going to lose sodium.